Hello and welcome to the Medicaid and CHIP Payment and Access Commission's Medicaid 101 series. Today we'll be talking about nursing facilities. But first, a little bit about the Medicaid and CHIP Payment and Access Commission, or MACPAC. MACPAC is a nonpartisan legislative branch agency that provides policy and data analysis and makes recommendations to Congress, the Secretary of the U.S. Department of Health and Human Services, and the states on a wide array of issues affecting Medicaid and the State Children's Health Insurance Program, or CHIP. MACPAC conducts policy research and analysis that is fact-driven and evidence-based. For more information, visit macpac.gov. This presentation is part of a series to provide educational content and highlight recommendations that the Commission has made previously. This presentation will focus on nursing facilities. In our presentation today, we'll be walking through some general background first, the types of nursing facilities, the residents who live there, how the system is financed, and how it is regulated at the federal level. Then we will discuss how COVID-19 has stressed an already struggling industry, and to walk through the role Medicaid plays as the primary payer of nursing facility care, before finally discussing MACPAC's recent work and recommendations in this area. General nursing facility background, types of facilities. What is a nursing facility? First off, while other organizations and advocates use the more colloquial nursing home, we've opted to stick with nursing facility as that is the term used in the Medicaid statute. Nursing facilities are institutions certified by a state to offer 24-hour care for those who don't require a hospital level of care. This places nursing facilities in the continuum of post-acute care options between home health providers, offering a lower level of support, and rehab or long-term care hospitals offering the greatest amount of support. While there's a concerted effort to rebalance long-term care away from institutional options toward home and community-based services, or HCBS, a number of individuals in nursing facilities cannot be served in the community due to complex care needs or a lack of affordable housing. Nursing facilities can be part of a hospital or freestanding, the majority at 97%. Facilities can also be part of larger continuing care retirement communities that may serve other segments of older adults, such as assisted living. While not exclusively, nursing facilities tend to serve older adults with age-related disabilities. The average nursing facility is fairly large at about 100 beds, but only a small number of facilities have fewer than 25 beds, which includes concepts like greenhouses that aim to provide home-like environments. Nursing facilities are largely run by for-profit organizations, and about 2/3 are affiliated with a chain. A variety of staff are employed by nursing facilities, but there are three main categories of workers that provide direct care to residents: registered nurses, who oversee care; licensed practical nurses, who provide more routine care; and certified nurse aides, who generally assist with activities of daily living. The staffing mix may vary by facility, but CNAs serve as the backbone for resident care, accounting for 2/3 of the direct care workforce. These positions are often paid close to minimum wage, and more than half of CNAs are people of color. Facilities generally serve two types of residents: short-stay patients and long-stay residents. Of course, a number of facilities may specialize and either primarily serve short-stay patients providing rehab, or they may have a high number of long-stay residents. About half of those in a nursing facility have a stay of less than 100 days, typically receiving skilled nursing care after a hospital stay. The other half of residents have stays longer than 100 days, and usually receive less intensive care supporting activities of daily living. That being said, these residents are still determined to require nursing facility level of care. Short-stay and long-stay residents differ in their level of nursing care needs, but also notably in which payer covers their stay. Medicare covers skilled nursing facility care for up to 100 days, while Medicaid covers both short and long-term care, typically as a secondary payer to Medicare in those first 100 days. Most nursing facility residents covered by Medicaid are duly eligible for Medicare as well, 84%, which means that Medicare continues to cover some costs for long-stay residents, like ancillary services and therapy through Part B. As you can see in this pie chart analyzing 2019 data, Medicaid pays for 59% of nursing facility residents, largely long-stay, but a notable amount of short-stay patients as well. While most are covered by either Medicaid, Medicare, or both, there's a substantial number of residents covered by private pay or other payers, such as Veterans Affairs benefits. According to the National Health Expenditure data, revenue for nursing facilities and continuing care retirement communities totaled $174 billion in 2019. Medicaid served as the largest source of revenue at 30%, but out-of-pocket spending was also substantial. This can include those with medically needy spend-down, beneficiary contributions, or private pay residents, especially as this data doesn't distinguish between nursing facilities and those with attached assisting living. The revenue Medicaid provides to facilities is less as a share of the total than the proportion of residents whose primary support is Medicaid. Medicaid payments are generally lower than other payers because of differences in the services that Medicaid covers. Long-stay residents generally have less intensive nursing and therapy care needs than short-stay residents, so the costs of their care are lower. Medicare Part B continues to pay for some physician and therapy services for many long-stay residents, and so these services are not included in the Medicaid rate. Because of Medicaid's spend-down and post-eligibility treatment of income rules, many Medicaid-covered residents pay for a substantial portion of their care out of pocket, which reduces the amount that Medicaid pays the facility. Medicare typically pays facilities much more than the costs of care for Medicare-covered patients. In 2019, freestanding nursing facilities reported a 20% aggregate Medicare profit margin, compared with an aggregate non-Medicare margin of negative 2%. Medicaid payment rates vary widely by state, as we'll see. According to our analyses of Medicaid base payment rates reported in TMSIS in 2019, Medicaid nursing facility payment rates varied widely, both by state and by facility. Although Medicaid rates are often lower than costs, we found that Medicaid payments appear to exceed the costs of care in some facilities in 2019. The median facility had payment rates that were 86% of cost. However, about 1/5 of facilities had base payment rates greater than 100% of costs, and 15% of facilities had base payment rates less than 70% of costs. More on these analyses can be found in our 2023 March report to Congress. Nursing facilities who accept Medicare and/or Medicaid payments must be certified by Medicare or Medicaid, which means they accept minimum federal standards set by the Centers for Medicare and Medicaid Services. Nearly all nursing facilities are duly certified. In order to ensure compliance with these federal minimum standards, state survey and certification agencies regularly assess facilities, and non-compliant facilities receive fines until they come into compliance or lose their certification, which would almost always result in its closure. The Affordable Care Act included a provision that a portion of the funds from these penalties be made available to states for quality improvement activities. Other initiatives, such as ombudsman programs, work to advocate for residents. Currently, the federal minimum staffing standard requires an RN or LPN be available 24/7 and a director of nursing, often responsible for infection control, be available for 8 hours a day. This works out to roughly 0.3 hours per resident day for the average facility. Many states set their own standards above the federal minimum. In April 2022, CMS requested information from stakeholders about raising federal minimum staffing standards, noting an often mentioned 2001 CMS study that suggested 4.1 hours per resident day was needed to reduce risk of harm to long-stay residents. Currently, few facilities staff at this level, and only DC requires it. Staffing is one of several measures that CMS uses to score nursing facilities on Medicare.gov Care Compare, a public site that allows residents and their families to evaluate nursing home quality. Along with staffing, star quality ratings are based on short-stay and long-stay quality measures and survey and inspection results, which receive the most weight in determining a star rating. Unlike a lot of other providers, researchers have a wealth of data on nursing facilities that can provide insights into questions like staffing, race, and ethnicity, and more. Other sources of nursing facility data include CASPR, which covers the universe of certified nursing facilities, the minimum data set, Medicare.gov Care Compare, which switched to a more accurate audited payroll-based journal system for measuring staffing in 2018, and Medicare cost reports, which have standardized data on costs for facilities participating in Medicare.
Now I'm going to speak about some of the recent quality and access challenges highlighted by the COVID-19 pandemic and Medicaid policies that might help address some of these challenges. So first, as we know, COVID has had a disproportionate effect on nursing facilities and their residents. Over 200,000 residents and staff have died so far because of the pandemic. Although nursing home residents are more susceptible to COVID because of their poor health status, the toll of COVID has also been exacerbated by longstanding quality challenges. For example, racial and ethnic minorities in nursing facilities have been particularly hard hit because of the underlying disparities in care for Medicaid-covered residents. COVID has also had a disruptive effect on the nursing home industry, as nursing facility occupancy has declined substantially and has been slow to recover to pre-pandemic levels. The number of nursing facility staff has also declined since the start of the pandemic. However, staffing rates per resident day have been relatively stable because of the declines in occupancy. There have been a number of state and federal policy changes to help respond to the large toll that COVID has had on nursing facilities. In the early days of the pandemic, there were a number of new infection control measures that were implemented jointly by states and CMS. Later, as part of the CARES Act, Congress created a provider relief fund to help offset provider losses. Some states also used CARES Act funds to increase payments to nursing facilities. After the CARES Act funding ran out, some states have also chosen to use state funding to increase Medicaid payment rates to nursing facilities. In MACPAC's recent review of staffing policies in 2021, we found that 12 states increased state minimum staffing standards, and 8 states added new payment policies to incentivize higher staffing rates during the pandemic. CMS also changed some federal staffing guidelines and is currently considering raising federal minimum staffing standards. So now that we've covered some general background about nursing facilities, let's focus on Medicaid policy, starting with the rules about who is eligible for nursing facility care. Many Medicaid-covered nursing facility residents are eligible under mandatory SSI-related pathways for seniors and people with disabilities. The Medicaid statute also provides the option for states to expand eligibility to higher-income individuals who have a nursing facility level of care. In 2018, 42 states had adopted this pathway, known as the Special Income Rule. In addition, 25 states also have medically needy pathways that nursing facility residents can use to spend down their income in order to qualify for Medicaid. Unlike other types of Medicaid benefits, nursing facility residents are required to contribute a portion of their income towards the cost of their care. The cost-sharing amount is equal to the difference between a beneficiary's income and the personal needs allowance, adjusted for SSI benefits and other deductions, with some exceptions. The personal needs allowance in most states is quite small, about $50 in FY 2018, which means that residents contribute virtually all of their income towards the cost of their care. These contributions can be substantial, and they're important for our analyses of payment policies because payments from the beneficiary reduce the Medicaid payments that the nursing facility receives from the state. So now let's look at payment policies in more detail. In general, we can group Medicaid payments to nursing facilities into 2 main categories: base payments for services, which are directly tied to care for particular beneficiaries, and supplemental payments, which are typically made in a lump sum for a fixed period of time. In 2019, about 6% of Medicaid nursing facility payments were made through supplemental payments. Most Medicaid payments to nursing facilities were made through fee-for-service, but the use of managed long-term services and supports is growing. In 2019, we estimated that about 1/3 of payments to nursing facilities were made through managed care. Fee-for-service base payment rates are typically paid on a daily rate known as a per diem. MACPAC has developed a compendium of state fee-for-service nursing facility payment methods in 2019, and we found that most states established rates based on facility costs, whereas 15 states developed their payments using a predetermined price, which is typically based on historical costs updated for inflation. States also make a number of adjustments to base nursing facility rates, including adjustments for patient acuity, high-need conditions, such as ventilator use, and geography or bed size. Regarding acuity adjustment, it's important to note that Medicare recently switched to a new acuity adjustment system in 2019, moving away from the RUGS system that many states had used and moving to a new patient-driven payment model, or PDPM. The Commission has examined the use of these different acuity methods and noted that PDPM is not a particularly good measure of therapy needs for Medicaid-covered residents. Last but not least, managed care is a growing share of Medicaid payments to nursing homes. In general, at MACPAC, we have found that managed care plans typically pay nursing facility rates that are similar to fee-for-service, but this is not required in all states. Also, some states have begun using managed care directed payments to require health plans to make additional payments to nursing facilities that are similar to supplemental payments in fee-for-service. About half of states make supplemental payments to nursing facilities, and according to MACPAC's analyses, the majority of supplemental payments are targeted to government-owned facilities. During interviews with states and other stakeholders that the Commission held in 2020, we learned that these payments are often financed through intergovernmental transfers. In addition, we noted some arrangements where public hospitals buy or lease privately operated nursing facilities in order to receive supplemental payments. In the aggregate, base and supplemental payments cannot exceed the upper payment limit, which is based on a reasonable estimate of what Medicare would have paid for the same service. States are required to demonstrate compliance with the UPL annually by submitting UPL demonstrations to CMS for review. States and the federal government jointly finance Medicaid nursing facility payments according to the state's federal matching assistance percentage, or FMAP. In general, the non-federal share of Medicaid payments can be financed through a variety of sources, including state general funds, provider taxes, and intergovernmental transfers or certified public expenditures from public entities. Overall, in our review, we found that the use of nursing facility provider taxes has grown from about 22 states in 2004 to 45 states in 2019. One of the reasons the Commission has done so much work in trying to understand nursing facility payments is because we're trying to understand the extent to which Medicaid payment policy can help address quality and access challenges for Medicaid-covered nursing facility residents. Principal among these are the health disparities that we observe between facilities that serve a high share of Medicaid-covered residents and those that don't. Some of these disparities may be a result of Medicaid payment policies, but some may also be a result of the fact that Medicaid-covered residents generally have a much more difficult time being admitted to high-quality facilities. Federal rules prevent nursing facilities from discriminating based on payer status once someone is admitted, but in many states, nursing facilities can choose whether or not to admit residents who are likely to become Medicaid eligible. This figure shows the disparities in star quality ratings between facilities that serve the lowest share of Medicaid-covered residents in dark blue, and the facilities that serve the highest share of Medicaid-covered residents in light blue. High Medicaid facilities generally do worse on all measures, especially staffing, which has been an area of focus for MACPAC's recent work. This table looks at how Medicaid payer mix relates to race and ethnicity of nursing facility residents, as well as facility ownership characteristics. We can see that facilities that serve a high share of Medicaid residents, in the right column, generally serve a higher share of Black and Hispanic residents. And so the quality differences in these facilities help exacerbate health disparities. In addition, we note that facilities that serve a high share of Medicaid-covered residents are more likely to be for-profit. This ownership status is also associated with lower staffing rates. In 2021, MACPAC did a literature review to identify state policies that could help address staffing issues. And we identified a number of different tools that states can use, including increasing Medicaid payment rates to help facilities hire more direct care staff and pay them higher wages, changing Medicaid payment methods to incentivize facilities to spend more of their revenue on staff, and setting state minimum staffing standards that exceed federal requirements. Another important quality issue that we've been monitoring is avoidable hospital use, which is particularly common for Medicaid-covered residents. Addressing this challenge is particularly difficult for patients dually eligible for Medicare and Medicaid. Recently, we've been monitoring some new models implemented by the Centers for Medicare and Medicaid Innovation to test new ways to help reduce avoidable hospital use. Unfortunately, the early results of these models were mixed, suggesting that more work is needed. Based on all these findings, the Commission developed a set of payment principles and recommendations for nursing facility payments that's described in MACPAC's March 2023 report to Congress. Overall, the Commission outlined 3 broad payment principles for states to consider when setting their payment methods. The first is that payment rates should cover the costs of economic and efficiently operated providers. When defining economic and efficient, the Commission noted that it's important to consider all costs of the facilities, including costs needed to meet staffing requirements. On the other hand, the Commission is also concerned about related party transactions and other activities that may inflate reported costs. Overall, the Commission has stressed the importance of considering all Medicaid payments that providers receive. Commission's second principle is that Medicaid payment methods should incentivize better quality and reduction in health disparities. The Commission has highlighted that Medicaid payment policy is particularly important for addressing disparities by payer mix, but also notes that more evaluation is needed to help policymakers identify the most effective strategies for achieving these goals. Finally, the last principle the Commission articulated is around efficiency and the importance for states trying to get the maximum value for the amount that they're spending. In order to identify opportunities to improve efficiency, the Commission has noted the importance of more cross-state comparisons of payment rates and quality outcomes. In addition, the Commission has also flagged there may be opportunities to better align Medicare and Medicaid payment policies to help promote efficiency. Ultimately, the Commission made 2 recommendations to help support these principles. The first recommendation is related to transparency of payment data, financing, and nursing facility ownership information. Transparency has been a longstanding goal for the Commission, since complete data on Medicaid payments to providers are needed to inform assessments of payment policies. To help stakeholders evaluate nursing facility payments, it's also important to collect comprehensive data on nursing facility finances necessary to compare Medicaid payments to the cost of care for Medicaid-covered residents. Although Medicare cost reports do provide some information on nursing facility finances in a standard format, our review of available cost data found several gaps that could be addressed if CMS required greater transparency. Our recommendations specifically call out the need for more transparency of related party transactions, which the Commission noted may inflate costs above what they would be if a facility were operated more economically and efficiently. And the recommendation also calls for transparency of real estate ownership models, which are important for understanding those related party transactions, especially arrangements in which the nursing facility real estate is owned by one entity and then leased to another. The Commission's second recommendation highlights the need for more state-level analyses of nursing facility payment rates. Federal regulations currently require states to make annual findings that fee-for-service nursing facility rates are reasonable and adequate to meet the costs of efficiently and economically operated providers. However, CMS has not enforced this requirement since the repeal of the Boren Amendment in the mid-1990s. The Commission's recommendation notes a number of updates that CMS could make to existing requirements, including adding analysis of how payments relate to quality outcomes and health disparities. The Commission's recommendations also underscore the need for CMS to provide states with analytic and technical support to help complete these analyses. Thank you for listening to MACPAC's 101 presentation on nursing facility policies.